Welcome to the Dogtor Bros, where we have an honest discussion around vet life in and out of the clinic. My name is Adam, and I am your doc of the day. Today, we are going to be continuing our discussion on Cushing's disease. This episode is part 2 of this discussion. If you haven't already, we encourage you to go back to last week's episode to catch up on part 1. With that being said, let's jump right back into the discussion.
All right, you ran the test, you have a positive, confirmed positive. What is your initial workup for these cases?
You mean the treatment?
Yeah. Like your initial, from the patient walking into your clinic, you run the test.
Yeah.
It's positive. What are you doing?
It's immediately going on Betterol. I'm going to keep it fairly short and sweet because it is proven that it works. It works well. There are side effects. I warn my clients that there can be some vomiting, diarrhea. They will have to do some follow-up ACTH sim testing to track it. And I give mine BID. Don't ask me the dose. I have it written down somewhere. Brandon probably knows it by heart. But I usually start them on Vetterol. There are several others. Mitotane isn't implicated. You have to be very careful with it because it can destroy the entire adrenal cortex. So that is where a lot of our cortisol is being made. Specifically, I'm not going to go into the specifics. I know the specifics, and it's just not that important. That's boards level material. But there are different layers in the adrenal cortex. Mitotane has been an older treatment that can actually destroy multiple layers, and one of the areas where cortisol is made, good gracious, is a part of that. But you do run the risk of potentially making a patient Addisonian, which some actually was a way to treat some of these cases back in the day. They used to purposefully make them Addisonian and then treat them as Addisonian cases. Adam is making a face.
Oh no!
Yeah, I didn't like that. So Mitotane
can have one bit.
Mitotane can have some significant side effects. Actually, interested to hear what you think, Brandon, on that.
Yeah, this is Brandon again. I honestly like Vetterol or Trilostane is my go-to as well. I think it's the easiest, and you just have to set expectations. We've talked about this before with clients and like managing expectations, but usually we have to start them at a specific dose and then slowly increase the dose or adjust the dose. And there's a lot of monitoring required. So as long as clients are on board with the game plan, we should be good. I won't go into super specifics. But part of it also depends on like the type. So if it's a pituitary-dependent, which is like 85% of these cases in dogs, the Trilostane would be my treatment of choice for like the majority of folks. I still always offer, and you all are going to look at me like I'm crazy, but you can legit go in there and do neurosurgery and cut out that adenoma from the pituitary. And there are places like, I think Washington State was the last place that we did it. We had a patient when I was a resident that went and got the surgery done, and then we managed them. Yeah. You can also radiate it too. And we did that because it was like starting to come back on that dog. The problem is there's a lot of other endocrine secreting tissues in the pituitary that like stimulate other endocrine systems in the body. And if you cut out part of the pituitary, you could also accidentally cut out a lot of those things. Unfortunately, you can just supplement a lot of that stuff. But that is something that a client, like if a client has absolutely no financial constraints and you confirm that it's a pituitary mass, usually by doing imaging, and then having a low dose dex that supports that, which is another benefit of that test, you can, feel pretty confident that you're dealing with pituitary versus adrenal dependent. Some folks will go for that. Not everyone. Not everyone's going to drop like $30,000 on a dog's neurosurgery and then manage things later. But people have insurance nowadays, so I always put it out there. And if people are like, "Ooh, like I would consider that," and they're like dead serious, then I will go into more detail. But oftentimes it's going to be treating with trilostane. Now, if it's an adrenal-dependent tumor, the recommendation is surgical removal, because that's a cancerous mass, usually some sort of adrenocortical carcinoma, and you want to get rid of that thing before it starts eating into other things like big vessels in the body, like the vena cava, the main vessel for venous return in the body. And then, you're avoiding the dog potentially having a hemoabdomen down the road. And that's where ultrasound comes into play with my diagnostic workup. If I've diagnosed it with ACTH-stim or low-dose dex, I usually am going to be recommending an ultrasound to look at the adrenals and see if there's a giant adrenal gland versus a small adrenal gland to help support the diagnosis of adrenal dependent, if that's what we're suspicious of. So that's what's going to be part of my game plan. But it's all dependent on the client. Like, some clients are like, I can't do that. I just wanted to get a diagnosis and do what I can for my dog to minimize these clinical signs, and that's fine. I just have a conversation with them. Like, if it's an adrenal mass, then that could be a big problem in a few years, if not sooner. If it's pituitary, we can usually manage this for a decent amount of time, but it all depends. And then there's the other aspects too. Like, I know Jeff probably doesn't think about this, but if the dog has proteinuria, like, they're at risk of clot formation, they might need to go on clopidogrel. You're aware, but you're not going to treat that.
No, I'm going to send them to you expeditiously.
Exactly. So yeah, like, if their protein loss is above a certain threshold, they might need to go on a medication to minimize clot formation. And one of the side effects of inappropriate clot formation is going to be like stroke or pulmonary thromboembolisms, like really major stuff. So there's that aspect. And then there's the other aspect of dogs with Cushing's disease and normally have high blood pressure. It's one of the few things that's on my short list for dogs that present with high blood pressure. And that's goes back to what we talked about. What kind of are they coming to you for? If I have a dog that comes to me for multiple multiple readings of high blood pressure at different times with their primary vet, and they're coming to me for further workup, Cushing's is on the list. One thing that I think people or vets that are maybe managing this on their own without maybe the owner can't go to a specialist or something else. They're like, okay, I treat the Cushing's, the high blood pressure goes away. It's not necessarily true. The data shows that they don't oftentimes present with high blood pressure. And then even if you're treating them and they didn't have high blood pressure, they could develop it after the fact. So you always need to monitor for it and then treat it appropriately if needed.
Yeah, and this is Jeff again. One of the things that I wanted to bring up we haven't really mentioned yet is this is a great type of condition where you can hear just from the options for workup that you really have to prioritize what is the pet coming in for, setting client expectations. This is a very, very expensive disease to treat, unfortunately. So all of even CBC Chem, et cetera, is getting pricey these days, but those ACTH stems, low-dose dex, those can be pricey all the way up to the thousands and thousands and thousands of dollars if you're trying to cut out a pituitary adenoma for Cushing's and to correct the clinical signs. And most of the treatment is primarily aimed at reducing those behavioral symptoms. So I really like when my cases do have at least some PU, PD, PP signs, those symptoms, because it makes it a lot easier to follow when I'm treating. Even for my cases, I'd say it's rare to have solely dermatologic symptoms and nothing else. And then I see the alphos elevated and catch Cushing's. And those are cases that I kind of step back and question and double check, does it make sense? Because Vetoryl is also, unfortunately, not a very cheap medication. So for skin, if I am suspicious of Cushing's, before I test, I have a conversation with the owner for, let's say, again, talking about a recurrent pyoderma case and nothing else is wrong with the dog and it's not really that itchy. And that is the only clinical sign that we can find, just skin stuff. I have a good conversation and I'm like, does it make sense to test for Cushing's? Yes. If it's positive, are we going to treat? Because I'm mostly trying to improve clinical signs over time. And I am aware, there's the other risks that Brandon mentioned that are very legitimate, which is, are we running the risk of clot formation by letting these go? Is my platelets increase on blood work, etc. So those are nuances that I kind of get into as they kind of come up in these cases. But I really prefer if I'm treating it. Obviously, they've come to see me for skin, but once it's treated, the skin takes months to improve, and often infections related to endocrine disease take a while because the cortisol has to get corrected, and then that gives the skin a chance to catch up. And it takes a normal, healthy, regular skin cell 21 days on average to go from baby skin cell to normal one, healthy, go away. When you have infections, it's super rapid and it takes forever for all of your individual skin cells to get in line, work together, start being healthy and grow normal. So that process can take months. I've had infections for some endocrine diseases that have not completely gone away for, the worst was like 6 months. So it's really hard for me to put a patient just in general on Veteral with only skin disease and watch them slowly improve. But the literature does show, like, if you don't correct the Cushing's, the infection may not completely go away. So it's that interesting nuance, that back and forth. I'm like, do I chase this with oral antibiotics? Am I culturing? Am I doing a lot of topical therapy on skin side and helping my skin barrier? And am I treating for the Cushing's? And I think most of the time they come along with those clinical signs that we see, which is helpful because I think from the client side, I want those clinical signs, the eating too much, drinking too much, peeing too much, to be going away much more quickly than months. We're talking like weeks. I don't know what you guys see in practice, but that's easier to chase when I'm starting meds for these really, because it's such an expensive disease, I find overall to work up and treat. So those are things to keep in mind, prioritize.
Yeah, I agree. It's Brandon again. The tests can add up, and then the monitoring can add up really quickly. So it's tricky. I try and like just mentally prepare clients. Because like we've all been there. Like you get a dog and they've got like everything. They're like reading the book when they walk in. They're panting. Their belly's like distended from the like the muscle wasting. They've got like muscle wasting in the back of their legs. Their coat's dull. You get the like blood work and it's just like classic across the board. You're like, okay, this is like almost certainly Cushing's. You still need to do your tests and everything else, but you can kind of start having a really like thorough conversation with the client then about like why you're doing the tests. This can be expensive. This is what we're going to need to do, assuming this is diagnosed, all this stuff. And then really quickly, Adam, just to kind of go back to what you'd asked earlier about low-dose dex versus stim in dogs with diabetes. You're just more like I found what I was looking for. You're more likely to have like a false positive with low-dose dex if they don't have Cushing's. I think the reason that that's a big deal is Cushing's and diabetes have a lot of overlapping clinical signs. They have increased appetite. They are peeing a lot and drinking a lot. So that's, and then they often will have like some degree of like elevated liver enzymes. So that's probably why that's important. And the stim would in theory be the better test if you're suspicious of like diabetes, or if it's a diabetic dog that you're also concerned has Cushing's. And oftentimes the reason you're doing that is because the diabetes is difficult to control, because insulin and high levels of cortisol don't mesh well.
Good to know, for sure. Going back towards the beginning of that question, I know that, Jeff, you said when you put patients on Veteral, you put them on a BID dose, which for listeners, that's twice daily. I have usually done an SID dose or once a day, but I have seen both as an option, twice a day versus once a day, kind of splitting that dose into twice daily dosing. So I was just kind of getting both of your opinions on what you've seen with that treatment, once a day versus twice a day.
This is Jeff again. I'll say the studies that I've read have indicated that I believe it is on the box as SID and it's not sufficient. So I usually go for a lower dose BID rather than the higher. I think I'm pretty sure the dose on the box is much higher than I go. So I go lower and go BID based on how the cortisol is supposed to be peaking in the body. And I know we haven't mentioned it yet, but I also almost exclusively do the name brand Vetaril because there's also studies showing that there's wild differentiations in the compounded versions as far as bioavailability.
Yeah, I totally agree. This is Brandon again. Like the FDA, so it goes back to the FDA approved dose, so to speak, which is listed as 2.2 to 6.7 milligrams per kilograms once daily with food,
which is a wild range.
Yeah.
Yeah.
And on top of that, on top of that, like it's already way higher than I would start with. Like I'm typically starting 0.5 milligram per kilogram twice a day.
Oh, wow.
Me too, I think. Now that you say that out loud, I think I do that as well.
Like that's pretty typical starting dose of that same drug. That it's the FDA approved one, trilostane, and because it's like we were talking about earlier, you don't want to overdose these guys and then make it so that their adrenal glands can't produce the steroids at all and then cause a whole other set of problems. So, like and you guys can tell me if you've had a different experience, but it's usually not an emergency to get this stuff. Like oftentimes the clients just want the clinical signs to be controlled, which is reasonable because the clinical signs are really annoying. And like most of these dogs, like this is one of those few diseases where dogs like generally feel good. Like usually if a dog is like vomiting or having diarrhea or other stuff, like Cushing's is not on my list, or at least it's not the primary problem. Because most of these dogs, other than having really annoying clinical signs of peeing a lot, drinking a lot, panting a lot, like they feel great. They're like, oh yeah, like I'm having a good time. Because steroids usually do that to dogs and to people for the most part, other than like those side effects. So yeah, like I'd rather start slow and do it right than overdo it with the quote unquote labeled dose.
Yeah, it's also probably good to keep in mind that Vetaril is not benign. So two things. Some common side effects, it can cause vomiting and diarrhea. Those are things that we sometimes have to deal with. And I feel like at the doses I go, it's been okay. But again, it's labeled much higher. And that's scary high to me. But there's also cases, I don't know if it's individual reports or a couple of studies. I'd have to go and double check my literature, but there are reports of it causing adrenal cortex necrosis. So you have to be careful like you would with any drug, and you need to monitor it. So ideally, some clinicians will monitor after starting it at the 2-week mark with a stim, 4 to 6 hours after giving the morning dose, or a month out. It kind of depends, but it's very important that the owner also knows to give you a heads up, warn them of signs of Addison's like vomiting and diarrhea, etc. And then you need to assess, is it the Vetaril, or are we accidentally turning the case Addisonian, or in the very rare case, and I do think it is rare, but we should keep in mind that it can cause adrenal cortical necrosis. So it is not a benign, let me just throw this at a dog and try it out. It's one where you have to prepare your owner. This may be lifelong, and we have to be careful with it.
Yeah, and this is Brandon again. That goes back to like mitotane too. Like the whole point of that drug is just to kill the cells. So
yeah, atom bomb the adrenal cortex, and I'm not interested. I'm scared of mitotane. There's a lot of people who are not. It's not for me. If it needs mitotane, I might call the internist and say, hey, do you use this drug? And
yeah, I mean, it'd be like really weird cases where things aren't as well controlled or something else. But that's like trilostane is going to be your go-to for sure.
All really good information there. And then last question that I have, because I know there's a ton that we have covered with Cushing's, and there's a ton more that we could to cover that we don't have time for. But the last question that I have here is in terms of follow-ups. So once you get the dog well regulated on a good stable dose, how often do you like to see those back? How often do you like to run stim tests to make sure they're on an adequate dose? Just briefly. And then for you specifically, Jeff, once you get them regulated or at least started for maintenance of Cushing's, do you refer back to their GP and just say, I'm taking the skin from here on, or do you continue to manage that Cushing's case?
What a lovely controversial question. So I'll say, I mean, I kind of mentioned my initial follow-up. If depending on cost and what the client can do, I check at the 2 weeks, plus or minus 4 weeks, and then around 3 months. Once they're happy and good and maintenance and we like where they're stimming, every 6 months is fine with me, with a 4 to 6 hour post morning pill check. And I will say, it's not that controversial, but like if a case was sent to me and I'm still managing their skin, I don't necessarily say you should go back and see another doctor, because if at anywhere along in that management, if I'm managing the Cushing's and they're having skin issues again, or they're still having problems, and to me, I'm like, this is a case where cutaneous signs have been seen with Cushing's. That was the underlying cause for what I've seen, and therefore I am managing it. So no, I don't specifically say you should go back and see another doctor. If I've diagnosed it, I kind of manage it for there, unless the client specifically requests to be seen elsewhere.
And this is Brandon. I mean, as far as like monitoring, it's kind of the same thing. Like, assuming we're treating with trilostane, like your biggest indicator of whether or not it's working is clinical signs. And that's the biggest indicator of if you're overdosing too, because then you'll have clinical signs of Addison's disease too. So, if usually within like 2 weeks, it'd be good to see them again, do a clinical evaluation, talk to the owner in person. Also be like monitoring blood pressure and that kind of stuff, especially if they already had a elevated blood pressure and we're working on that at the same time. And if they're doing really well, then I'd wait to the 3 or 4 weeks after starting treatment, and then do my first stim and see where the numbers lie. And there's cutoffs, so we won't talk about the nitty gritty, but like the big thing is going to be clinical signs. And if owners are noticing clinical signs popping up after we've established the dose that these pets are on, then, we need to re-stim them. If the clinical signs are well controlled, yes, just like Jeff said, if it's been like 3 months post-diagnosis, you want to just make sure that you're not overdoing things and things still look good. And then after that, I think 6 months is very reasonable. There's a lot of controversy, I think, like in academic circles, where people are like looking at like decimal points of nonsense. Like in the real world, who cares if the dog's managed well and the client's happy? As long as we're like checking our big boxes, it's fine. I don't like have a super strong opinion about like little individual things. I think the big thing that people need to be careful with is like if a GP is managing it, which I think they totally can, they just need to make sure that they're doing things correctly. So making sure like you're doing this ACTH stim 4 hours to 6 hours post pill. Like one of my mentors was very adamant that it only be about 4 hours post pill. Otherwise it's still inaccurate, which I kind of agree with. I started to see some little trends that made some sense just in individual cases. But like if you're just stimming the dog and they came in and they got the drug like an hour before they came in, like your results are going to be off. So managing it right, it is possible as a GP, possible as a dermatologist, possible as an internal medicine specialist. Like people can do it. And sometimes it's really important that GPs feel comfortable, because unfortunately not everyone has the ability to come to us. So I think that's the big thing.
And this is Jeff. Another two short things I wanted to point out are, especially in derm world, keep an eye out for Cushing's patients who get well controlled and then start to get itchy. So there's a lot of cases that will start to show their allergies because they've been well controlled on their extra endogenous cortisol. And then all of a sudden you've treated a really good Cushing's case. You're really proud of yourself. The clinical signs for Cushing's have resolved. Infection is improving. And then the client is calling you because they're scratching like crazy. That is because you've gotten the cortisol back in control. And now you have an allergy case to work up. So that does happen to me and can happen to anybody. The other thing I was going to mention is there are some dermatologists who absolutely do not work up endocrine cases. So it's very case dependent as well. It really just kind of depends. You asked me, Adam, like if what I do once they're well maintained. And it kind of depends on the derm that they're sent to, because there are some that will treat truly strictly just the skin and get it improved, and they won't touch endocrine, and it's immediately going back to the general practitioner or to the nearest internal medicine specialist. So that's very doctor dependent as well.
Yeah, I guess that makes a lot of sense, how much they want to stray from their realm of derm world. That is interesting, though, and that's a really good point I hadn't thought of those allergies popping up after you get the Cushing managed, because that steroid level is lower.
I was just going to add, like, you could say the same thing for diabetes, too. Like, if you feel really confident in your diagnosis, but the dog's still peeing a bunch, still eating a bunch, glucose is really high. If you didn't catch that initially earlier, maybe they were subclinically diabetic initially. Same kind of deal. Like, you just don't be afraid to do additional workup if the signs aren't resolving, but all your other tests make sense.
Yeah, for sure. I personally find Cushing's really interesting. I think it's one of the more interesting endocrine disorders, one of the more interesting disorders we manage in general. Just with what we've touched on today, there's so many factors that come into play with clinical signs you see, with the workup, with the treatment and management. There's just a lot of factors when managing Cushing's cases. So I find it really interesting, and I learned a lot in this as is. So thank you guys for the conversation. Just to round things out, we'll round things out with an outro question, and this will be a first for the Dr. Bros. It will not be the doc of the day asking the outro question. I'm going to defer my outro question to Brandon.
Yeah, this really spurred out because I already kind of know the answer to the question, so it's not fair if Adam asks it. And it's just topic related. So for you guys, who knows who is credited with the discovery of hyperadrenocorticism?
Dr. Cushing.
Okay. So yes. So can you go into more detail? Do you know why?
I cannot. Thank you so much. Absolutely not.
All right, and that's it. All right, we're done. No. So it's really interesting, actually. I don't normally get into medical history and that kind of stuff, but I mean, we're talking way back in 1912. Thinking about the medical field back then, was very, very different. So much we didn't know back then. He published information on a clinical case description, essentially, with a patient that had the classic signs of Cushing's. And later on, he also published information or some data on, he was suspicious that this was related to the adrenal gland, and that it was an oversecreting adrenal mass that could be causing it. And down the road, that was confirmed. But he's kind of credited with the original, discovery, so to speak. He put two and two together way back in 1912, which is just nuts to me. So that's why Cushing's disease has stuck with the name so strongly.
Thank you once again for joining us on the Dr. Bros.
If you would like to support us, please share this episode with others who may be interested in today's topic, and leave us a 5-star review on Apple Podcasts, Spotify, or wherever you listen to your podcasts.
Would you like to influence our next episode? We love hearing your opinions and thoughts. Your comments may be our next topic.
Please leave us suggestions via email at thedoctorbros@gmail.com, DM us at thedoctorbros on Instagram, or leave us comments on our posts. Again, this is Brandon. You can reach me at Dr. Mason IM on Instagram.
And this is Chris, and you can reach me on Instagram at dr.chrishernandez.
And this is Jeff. You can find me on TikTok or Instagram at DermDrJeff, DermDogtorJeff.
And this is Adam. You can reach me on Instagram at DrAdamDVM. That's DrAdamDVM.